Hello, I'm Dr. Yong here, one of the lecturers from Department of Ophthalmology. First of all, we'd like to welcome all of you to the ophthalmology posting, and would like to welcome you to the first ever e-learning from our department. I believe this is a very new experience, not only for me and also for my department. So for this slide and also this lecture, I would like to introduce to you some important ophthalmic examination techniques for you as a medical student. Okay, so today I have three important ophthalmic examination techniques that I would like to show you here. First is a pupillary examinations. Second is a visual field examination by the confrontation test. And the third is the examination of the eye movement by checking the extraocular muscle movement. In these presentations, I hope to guide you through all three examination techniques by first of all introduce to you the instrument that you will need, and then I'll let you know what will be the examination techniques that involve, and after this we show you some videos and pictures, and finally the most important thing is you have to apply the clinical applications when you examine the technique. So hopefully by the end of these presentations you'll be able to perform and also to interpret your findings from examinations. Our first topic is pupillary examinations. What you will need is rather simple. You will need two pen torches for you to perform pupillary examinations. There are two aspects in the pupillary examinations. One is inspections, one is checking the light reactivity. So for the inspection of the pupil, what you need to check basically is the size, shape, and also the locations of each pupil. And lastly, you have to document and also comment whether there is a symmetrical in the size, shape, and also the locations of the pupil. The second thing is the reactivity to the light. So you have to check for the light reactions, which consists of the direct reflex, concentric reflex, reactive afferent pupillary defect, and also the near reflex. To examine the pupil, first of all, it should be ideally in a dim room light. After this, you need to sit opposite the patient at the arm's length and ask the patient to look past you into the distance. This is to avoid accommodative reactions in which the patient pupil will constrict from the beginning. So the examination of the pupils will begin with the assessment of the size of the pupil and also the locations and also the shape as mentioned just now in the uniform light that shine to the patient's face and also the eyes. After this, we check for the direct light response. Shine the light from a pen torch into one eye and also assess the pupil constriction of the eye that you shine the pen torch to. So this will cause the direct pupil light response. The concentric reflex is the simultaneous constriction of the fellow pupil when you shine the light to the first eye. In the concentric light reflex, you will need a second pen torch for you to see the fellow pupil whether it's constricting or not when you shine the pen torch in the first eye. So the third light reaction is the reactive afferent pupil defect. We also call it as a Marcus Kahn pupil. So how we do it, usually perform a swinging light test. So after checking direct the pupil light response with the brightest light source that you can have of the second eye, you swing the light quickly back to the first eye. So you should be able to see both pupils should constrict equally. If during the swinging light test, if one of the pupils fails to constrict, and also it demonstrates the paradoxical dilatations of the pupil when the torchlight is swung from the contralateral good eye to the affected eye. This is actually called as a reactive afferent pupillary defect in the eye which fail to constrict, or in the eye which demonstrate the paradoxical dilatations when you swing the light to the pupil. Near reflex is simple. You ask the patient to look for a distance followed by a near object at about 20 cm from the patient, and then you shine the torch to the face to observe whether the both pupils constrict equally or not. Hello, I'm going to check your eye. So there will be a torchlight, there will be a bright light shine to your eye, there will be some discomfort. Okay, so now can look at the target at the as far as you're able to see. Okay, very good. Okay, just keep your eye open. A bit bright light. Very good. Very good. Okay, keep the eye. Okay. Okay, hi, I'm going to check your eye by shining a light to your eye. There will be some discomfort. First of all, can you look at the far target over there? Very good. Okay, so there will be some discomfort. Okay, just keep looking far. Good. Very good. Okay, so the next one, we're going to check for this one. Very good. Very good. Okay, next thing is to demonstrate to you what is IPD, which stands for Relative Afferent Pupillary Defect. Okay, set principle, the patient need to look for the far targets so that the pupil is relaxed. Okay, what we are going to do now is using a pen torch, just as in the one we do. Okay, to check the patient's one eye first. Okay, so you are expecting if the pupil is fully functions, so you'll be constricting. Okay, so after this, you need to go to swing to the other eye. Okay, to check for the reaction over the other eye. So you also will expect there will be constrictions because you're creating a direct reflex. Okay, so this is actually a combination of your concentric reflex. So you know that the other eye is at the same time is constricting as well. So this is so-called the swinging light test. So now imagine that the patient left eye, the optic nerve function is maybe just a 50%. So when you shine the light to the left eye, the pupil will still constrict around 50%. Okay. So what happens is you will think that this pupil is constricting normally, so you can have normal direct reflex. Okay. So when you shine your torchlight to the other eye, okay, so the other eye is a fully function as well. So there is 100% of optic nerve function. They will constrict even more. Okay, but you're unable to compare how much the constriction between two eyes. So what you're going to do is, so when you shine this eye, shine to the right eye, you know that the left eye now is also fully constricting because the right eye function is normal. So the efferent is almost normal. Go to the left eye. However, when you shine, swing back to the left eye because the function is less. Instead of the constriction that usually you will see, the left eye will be dilating because of 50% function of the optic nerve now. So that the input is 50% less compared to input over this eye. So you know that. So by doing this swinging light test, you're able to see constrictions over the right eye. When swing to this eye, left eye, instead of constriction, you see dilatations. Okay? Constrictions over the right eye, dilatation over the left eye. This is a swinging light test. Hello, I'm going to check your eye. First of all, I would like you to look at the far. After that, I will ask you to look at the near. Okay? So now try to look at the far first. So there will be some torchlight shining to your face. Don't worry. Okay, look at the far. Now look at the near. Okay? One more time. Look at the far. Look at the near. Very good. Look at the far. Look at the near. Very good. Hello, I'm going to check. Pupillary examination is one of the most important examination technique in the eye. Because the light reactions actually represent two different pathways. One is the afferent pathway, one is the efferent pathway. The afferent pathway is responsible by the optic nerve, which is the cranial nerve 2, and the efferent pathway is responsible by the ocular motor nerve, cranial nerve 3. So the impairment of the direct reflex will tell you whether or either there is an afferent problem or efferent problem, or can be both. but the presence of the concentric reflex in the eye can help you to prove that the efferent pathway is intact. IAPD, by doing a swinging light test, indicating either the optic nerve lesions, which is the most important marker, or either can be extensive retinal damage. Both of these conditions actually affect the efferent pathway. IPD is very important, especially when you have a patient with a fairly normal direct reflex and also fairly normal concentric reflex, but you're suspecting the optic nerve maybe have some impairment. So IPD can help you to detect the relatively less function of one eye optic nerve as compared to the other eye. Hence the terms of the reactive efferent pupillary defect come in. The second topic is visual field examinations by doing a confrontation test. The instrument that you need can be just either your finger, or it can be a tongue depressor with the red targets on the top, or it can be an orange stick with either the red pin or the white pin. The meaning of confrontation is basically you ask a patient to sit right in front of you at the same level, and the patient and you yourself will close the eye which is confined to each other. For example, when the patient closing the right eye, then you close the left eye. So the occluded eye is over the same side, and unoccluded eye is over the same side of both the examiner and also the patients. In the case that you are unsure the patient's visual function and visual acuity, first of all, you would like to check grossly whether how well the patient can see, at least whether can see your target. So you can check grossly with your finger counting at the center or your target in the middle of the field first. So the target is then brought from the outside, from the area that unable to seen by you and also the patients, then bring it slowly into the center of the visual field so that both of you will be able to see if both of your visual field are normal. So the patient will be asked to inform when they start seeing the targets. This is repeated for minimum of the 4 quadrants in the superior nasal, superior temporal, inferior temporal, and also the inferior nasal visual field. And the same procedure will be repeated with the other eye. So the size of the patient's visual field is compared to the size of the examiner visual field. So you by assuming that your visual field is normal as a doctor. So very important now is you need to check your visual fields with one of your friends. If both of your visual field is normal and is equal with each other, then you're able to proceed to check your patients. The other examination in the visual field is examination of the blind spot. The blind spot is assessed using a red target, moving it slowly from the temporal side to the center in the horizontal manner. The patient size of the blind spot is compared to the examiner blind spot as well. Hello, I would like to check your eye now. Don't worry, what you need to do is just sit right in front of me. Okay, now what I want you to do is, can you please close your left eye? Very good. Close the left eye with your palm. Okay, so to make sure that you see only with your right eye. And I want your right eye to keep looking at my nose, the direction of my nose. Okay, can you please tell me how many fingers you're able to see in front of you? Now, very good. Okay, you're able to see the finger now? No. Okay, very good. How many now? How many? Very good. How many fingers? How many fingers? Very good. Okay, same thing as well. Keep looking at my nose. You're able to see the red dots. Very good. Okay, keep looking at my nose now. You're able to see the red dot now. Okay, when you're able to see it, please let me know. Very good. You're able to see it now. When you're able to see it, let me know. Very good. You're able to see it now. You're able to see it now. Very good. You're able to see it now. When you're able to see it, let me know. Keep looking at my nose. You're able to see it now? Now? Okay. So, can you close the other eye? Close your right eye with your palm. Okay. How many fingers do you see? Very good. Very good. good. Very good. Tell me how many fingers? Many fingers. Very good. Okay, same thing as well. Be able to see red dots? Okay. Be able to see it now? No. When you're able to see it, please let me know. Very good. Be able to see it now? No. When you're able to see it, let me know. Okay, looking at my nose. Very good. Okay, close your eye with your palm. Can you see it with dot? When you're able to see it, let me know. Very good. Be able to see it? No. When you're able to see it, let me know. Very good. For visual field examination, there's always a question to ask what is the difference to use white and also red targets in the examinations. A white target is actually used to assess the visual field, especially at the periphery, because the periphery visual field are more sensitive to the white target. What is the reason? It's because of the presence of the rods and also the absence of the cones in the peripheral retina. Rod is usually responsible for the black and white visions, and cones is responsible for the color visions. So in the peripheral retinas, your rod is predominant, you will see black and white much better. A red target is used to assess the macular lesions and also the bright spot, because the macula and also bright spot is near to the center and you have a lot of the cones and it's more sensitive to the color, especially the red color. So the red color will be able to delineate the macular lesion and also blind spot much better if compared to your white targets. So the blind spot will be enlarged when the optic disc is swollen, like in the case of papillary edema and also the hypertensive retinopathy when this is advanced. The most important for the visual field defect examination is for you to detect whether there is any lesions along the visual pathway. So there are many classical visual field defects that you need to know. For example, bitemporal hemianopia in the optic chiasma lesions and also homonymous hemianopia in the postchiasmatic lesions. The last technique that I would like to show you is examination the extraocular muscle movement. So basically what do you need is still the same. You can use just your finger. It's the same target as what you use in the visual field examinations, especially it's a tongue depressor with the red target is there, so the patient easily to see and easily to follow. For EOM examinations, the patient also is sit in front of you, but different from the visual field examination is in these EOM examinations, you are assessing two eyes at the same time, so you don't need to occlude your patient eye and your eye as well during these examinations. So first of all, observe the position of the patient eyes by paying attention to any deviation of the eyeballs. Sometimes you'll be able to see obvious deviations of the eyeball from the center. Besides, you also can see and also can check whether there is any abnormal compensatory posture of the head due to the misalignment of the eyes. Another way that you can do is using a torchlight to shine a light to the cornea that you're able to observe for the corneal light reflex. This is called as a Hirschberg test. This is done when the patient is looking straight ahead in the primary position of the gaze. The corneal light reflex should be symmetrical and also near the center of each cornea. So when your eyeball is deviated due to your problem in the extraocular muscle of the nerve, the corneal light reflex will be seen as a deviated as well from the center. So next, examine the movement of the eyeball in proper. So you examine the movement of the eyeball in the ninth position of the gaze. So this ninth position of the gaze actually at the end tell you there are 6 cardinal positions that will be able to indicate 6 muscles that are responsible for your extraocular muscle movement. At the same time, you will determine if any double visions complained by the patients and any position of the gaze that lead to the nystagmus, which is an involuntary oscillating eye movement. The ninth position of the gaze will follow the Union Jack pattern, which I will demonstrate to you in the next slide. Okay, we're able to see this. Okay, can you tell me you're able to see 1 dot or 2 dots? Okay, there's only 1. What I want you to do next is I want you to keep looking at this and your eye follow this when I move the target as well. When you move your eye, try not to move your head. Okay, just move your eye. Okay, just follow this. Very good. And let me know whenever you suddenly see two targets in front of you. Okay, one or two now. Very good. Okay, now follow your eye. We are moving your head. Very good. Okay. Very good. Okay. Okay, follow again. Very good. One or two. Okay. Whenever you see two, let me know. Down. This one. This one. Very good. So for the EOM examination, it's very important to observe the night gaze positions when patient move the eye. So we can see the night gaze photo in this slide. So in the middle will be the so-called is a primary gaze when patient looks straight. So when patient look to the left, we call it a leval ductions. When patient look to the right, we call it a dextral ductions. So when patient look up, both eye, then we call it a elevations. When patient look down, both eye, we call it a depressions. So how about a patient look to the left and up? Okay, there are many terms. You can call it as a combination of the left and up is a leval elevations. Left and down is a leval depressions. When patient look to the right and up, there will be dextral elevations. When patient look to the right and down, there will be dextral depressions. After observing for the 9 position of gaze in the EOM examinations, the most important information actually in the 6 cardinal diagnostic positions, because these 6 cardinal diagnostic positions represent individual extraocular muscle in your eye. As you all know, and you all should know now is we have only 6 extraocular muscles responsible for the eye movement. So for example, for your eye to look to outside from your nose, then is responsible for your rectus muscle. For your eye to look in to the nose, responsible by the medial rectus muscle. So how about for your eye to look up and look down? Look up and look down itself at the middle vertical positions, actually responsible by the combination of the muscle. We call it the elevator muscle. Elevator muscle consists of the inferior oblique and also superior rectus. So the elevation impairment cannot further tell you which of the muscle got problem, but we're able to further divide it by ask the patient to do level elevation or dextral elevations. If the eye is unable to look up and out, it's the problem of the superior rectus. If the eye is unable to look up and in, it's a problem over the inferior rectus. Same thing apply for the depression muscle. So if the eye unable to look down and up, it's due to the problem of the inferior rectus. If the eye unable to look down and in, it's due to the superior oblique muscle. So by looking at the EOM and also the 6 cardinal diagnostic positions, you will definitely able to tell me which positions is have restrictions, and then you can suggest to me this position is usually responsible by which muscle, and then you can further suggest to me this inactivations and also the reduced function of this muscle can due to either the muscle problem by itself or can be due to the nerve problem. Sometimes you are unable to differentiate it from the clinical examinations, which will warrant a further test. But at least you're able to tell me which positions and which muscle is responsible for your for the defect in these patients. Okay, I think this is the end for the presentations and also my lecture. I believe that it will be quite difficult for some of you to follow because it's basically is a clinical lecture. Ideally, you all should be with me that I able to demonstrate to you, and also I see how you perform the examinations. So if you have any questions, first read the slide again. You can always double check with your friends, and then you can always double check with your books. If still fail to solve the problem, then you can always welcome to email me. The email is attached in the slide.